Welcome everyone to HIV Rounds, and sorry for the delay. The room was booked ahead of us and it just takes a few minutes to get set up. So thanks for spending your lunch hour with us, and we're going to talk a little bit about a project which I'm involved in. And I'm so pleased to have the support staff here with me as well, because nothing you do with HIV and hepatitis C in the population can be done in isolation. It takes a group. So thanks to everyone here and that's listening in. That helps me when I call and I'm in a bit of a crisis trying to figure something out. So we'll talk about out and about in the community, successes and challenges. This is sort of part one. So this is just from the beginning to the point we're at now, which is 6 months into the project. And later on, hopefully next fall, we'll be able to talk to you a little bit about some numbers seen, and some of the data that we've collected as we've gone along. That's a bit of a in process right at the moment. So the objectives here, we're going to talk a little bit about epidemiology. Why do we need a project where folks are out and about in the community? What are some of the barriers that we meet when we're out in the community, the challenges, our successes, and what we look for in the future? So Saskatchewan at a glance, and I think we're all fairly well aware of the state of emergency. HIV rates in Saskatchewan rise again in 2016. It was something that was recognized by many groups. I'm not sure lots of changes yet have been made, but little projects like mine are the steps in infancy towards making bigger changes. So you have to sort of start somewhere. And myself and the Wellness Wheel that Suzanne Nicolay has are some of those projects that sort of reach out into the community and address some of the issues that go along with the state of emergency. So there's a little slide that was created by the Ministry of Health and the Epidemiology of HIV in Saskatchewan. So you can see there are some hot spots. Some of the urban areas aren't so much a hot spot, but I think we have to add a but to that. Have we reached out to some of the folks that are easy to reach and tested the easy to reach folks, but the folks that aren't easy to reach are still remaining untested and potentially fall into that category of the 25% who are living with HIV but unaware of their diagnosis, and who studies have shown are possibly transmitting and creating more than half of the new infections. So we do still need to not forget about our urban areas, especially the large urban areas in Saskatoon, Regina, and Prince Albert. And so this is what my piece of my project and my work takes me to in the urban areas in Regina. Hepatitis C, again, people are under-tested. And so it's right across our population. We know that folks, baby boomers, potentially are living with hepatitis C and undiagnosed, and not until they have something abnormal on an annual physical with their liver enzymes does someone twig in that they should be tested. Last year, the new diagnosis of hepatitis C equaled the number of persons treated. Not acceptable. We need to test more, we need to treat more, we need infrastructure that supports that, and we have a long ways to go. We don't even really know what our numbers of persons living with hepatitis C in the province are. In a recent talk, Dr. Wong talked about 15,000 to 25,000. Is there that many, or are we overestimating? Are we maybe underestimating? Maybe there's even more than 25,000. Who is going to treat those folks? Who's going to engage them in care? Family physicians need to be educated. There's lots of different problems and concerns around all of these processes, and I'll talk a little bit in stories as we go along about some of the folks I encounter when I'm out and about in the community. So why do we need a project like mine? Why are folks not getting tested for HIV and hepatitis C? There's many challenges, there's many barriers, there's many voice concerns and problems. The list is very long. And I love that little icon there, that little fellow sitting on the question mark. What do we do? What do we do? How do we solve so many of these problems? So we need to identify the problems first. And the first big one, of course, is stigma and discrimination. And you would think, since HIV has been around since the early 80s, we would have overcome that stigma and discrimination. Although our epidemic came along a little bit later than everyone else's, stigma and discrimination is still a very large barrier problem for folks. And I think it was highlighted, and I don't know if anybody saw, the Saskatchewan Union of Nurses did a sort of small documentary around HIV. And when it got onto Facebook, it was very evident that there is still a lot of stigma and discrimination around HIV. Some of the comments that were written about the material that was covered within that documentary were virtually hateful in some cases. So we have a lot of work to still do, and it starts with you. You need to talk about HIV. Don't be afraid to talk to your friends, to your family, to your coworkers about the work that you do when you're reaching out to folks that are living with HIV or hepatitis C or those at risk. Because the more we talk about it, the more folks ask questions, the more they understand that we can control HIV, that we can cure hepatitis C. These are things that not everyone in the general population knows about or understands. And I think the more that we talk about it, it's up to us to do that educating piece. Fear. Many of our folks living at risk are afraid. And I just encountered someone this morning on the phone who I have been trying to find. I put her on my list. I asked for her to be sent to talk to me, and day after day, her name reappears on my list. So this morning, I was at a different site, and I asked for her, when she came to pick up her methadone, to give me a call. So when she, it doesn't seem so challenging, I guess, to pick up a phone and talk to somebody at the other end of the phone. And sure enough, she called. And when I talked to her about why I wanted to have a meeting with her, she goes, "Oh, I was so afraid to talk to you. Thank you for being persistent." But it was her fear that was her barrier to talking about her hepatitis C and the fact that she can be treated and that, she has a great chance of a cure. But she was afraid to talk to me, to come and meet with me and have that discussion. Access. And I know when we look at access, we talk often about rural and remote, but even living in the neighborhood in Regina, I may have limited access. It may be that I've had a bad experience at a hospital. It may be that I haven't been able to get an appointment. I don't have a primary care provider. I go from Mediclinic to Mediclinic. I go to the emergency department. I never have good experiences. And so my access to care is still limited, even though I live 2 blocks from somewhere where I can get an HIV or hepatitis C test. So don't forget about those folks in urban areas. There still is access issues. I may live in isolation. I may be afraid to talk about the risks that I have. Maybe I only used once and shared a needle with someone 6 months ago that someone is telling me is living with HIV or has hepatitis C, but I don't want to talk about it. I don't know anybody that I can talk to. So I live in isolation, I live in fear, and I don't get tested. Poverty and those social determinants of health. Poverty is the top of the list. Our folks that live in poverty have many, many barriers. They don't have a house. If I don't have a house, if I don't have a car, if I don't have food on my table, am I going to be able to access a test, be successful with treatment? Not likely. Addiction can get in the way. We don't want addiction issues to get in the way, especially with hepatitis C testing and treatment. And there are perceived notions out there that if I'm still using, that I shouldn't be treated. That's wrong. I just need to be stable enough to be able to take my 84 pills and complete my therapy and stay linked to care and understand what my risks are and to prevent myself from getting reinfected. And so maybe it takes a little bit more work on the part of the care provider to make sure they understand how important it is to reduce their risk while they're on treatment and after they've been treated and successfully cleared the virus. It's really important, that education piece, but addiction should not be an issue. Mental health. We know mental health services are very limited in Saskatchewan, and for many who really should have access to mental health services, it isn't there. And so they struggle, they wander, people look, they don't have a family physician, they end up in the emergency department time and time again. Sometimes they leave because they can't, they don't want to wait long enough, or they run out of medication, or because they've had an issue somewhere, they aren't allowed to seek care somewhere. Mental health is a huge barrier. And for some, lack of available services. And I talk a little bit about family physicians, and I know there's lots of work afoot for family physicians and nurse practitioners to be educated to care for persons living with HIV, It can be done. It certainly is done in other parts of the world. And hepatitis C in Australia is a great example of how they've spread hepatitis C education and care into the communities where primary care providers, whether it be a physician or a nurse practitioner, can definitely take on that task, that challenge, and diagnose and treat. If I get diagnosed by someone, wouldn't it be great for continuity of care to be able to be treated by that same person rather than having to be referred somewhere to go, have to park and register and go to a place that I don't know, but rather go to my familiar site and be tested and treated and cured at that local site with hepatitis C? Wouldn't that be great? Again, lack of trained professionals, and we know that there are a lack of family physicians. I think in Regina it's maybe a little bit better than it was, but we still know that there's lots of folks living in urban areas, or even in urban areas such as Regina, that don't have access to a family physician. And I could go on and on. There's many different problems. Those are just some of the larger ones. And I put so few answers. Do we have the answers? We have to think. We have to have support. We have to have groups that can work together. And most of all, we as nurses and care providers, we need to advocate, because if we advocate and we begin to push and we bring these problems to the forefront, hopefully someone takes notice. So here's some of what I see some days. And I didn't even know what to put a title there. I thought the picture just was self-explanatory. And, many days I put my arm around folks and give them a hug and make sure they've got that money for a coffee or a granola bar. And that simple caring piece, that smile that you provide them, will bring them back to you. And I hear now, after I've been going to many of the locations for 6 months, I'll hear someone coming in and calling me by name and asking if I'm there today. So let's get rid of the problems and let's talk about some solutions. So the first solution, and I don't know, I certainly do not have all of the answers, and I'm just taking baby steps. And sometimes, I think I've taken 2 great steps in a day, but then suddenly I've taken 5 steps back. So it's the persistence and the continuing to be out in the community and to be present that is how we're going to make change, how we're going to engage that population. So I thought this was interesting. In Canada, the social determinants of health include disability, food insecurity, race, Aboriginal status, employment and working conditions, income, social exclusion, social safety net. How many of our folks come and live in isolation, and when you ask them, do you have someone that can help you? Who would you call in a crisis? Who would be able to help you? They don't have an answer. They don't have someone that they can lean on, that they can talk to. Housing, education. Many folks, I've seen a few young folks that kind of hang around where I hang around, and I'm always wondering, how come they're not in school? They're not attending, and it bothers me. Gender and gender identity, health services, and disability. So we can see that some of the folks that we interact with have many of these, are missing or lacking or have a weak social determinants of health. Are there solutions? There's no easy answers, but sometimes that advocacy piece, and I see 2 people with question marks above their heads. I think it should be a whole group of folks, because sometimes it takes many, many calls. There was just a situation where we were talking about dressing changes for someone, and I probably made 8 phone calls. And in the end of the day, I finally got the person to show up, and the wound had begun to heal itself. And currently, the dressing changes weren't an issue. But, that was probably a couple of hours of phone calls. But at the same time, people were asking what I was doing, where I am, and so I was spreading the word about what I do. So our goals are based upon the continuum of care, both for HIV and hepatitis C. And so this is the HIV continuum of care, and you can see it I like this sort of diagram of the continuum of care because it can be a very steep slope. The first step is actually getting the test and being diagnosed. The second step is actually being linked to a healthcare provider. So that means having that first appointment arranged. The second one is the third step is actually being retained in care, continuing to go for care as often as I'm asked to go. So whether that's it might be every 6 weeks for a while till I'm stable. Maybe I've been living with HIV for a long time, and so I'm only going every 6 months or once a year. The fourth step is actually taking HIV medication. Okay, having that prescription, getting the prescription to the pharmacy and picking the prescription up and being able to take the medication once a day. Whether it be that we link that medication to methadone, or whether we actually, the person takes home a month at a time or a week at a time, or whether it's packaged, however we provide the medication to the client. And the fifth one is actually having a non-detectable viral load. And once we have that non-detectable viral load, then we exit the continuum. But for many of our folks, what happens? Show you a little icon in a minute. We'll go through the hepatitis C and then we'll talk a little bit about what happens. So hepatitis C's continuum is even worse. And this is actually an actual Cascade where they actually looked, and this is from the Age Education Treatment Center National Curriculum. So it's a great curriculum if anybody wants to go to that site. It's actually a curriculum that anybody can do for free, and it talks about both HIV and hepatitis C, and you can work through all the different portions of that national curriculum, from epidemiology through to diagnosis and AIDS diagnosis, etc. Anyway, in this case, the total number of patients that accessed care were 748. So 748 had actually been diagnosed. About 562 of those, which represents the portion that need to be treated. The other portion would have spontaneously cleared their hepatitis C. So about 562 actually needed to be treated. So then of those 562, they were referred, and only 303 got a referral. So someone dropped the ball there. What happened to those folks that dropped into that piece? Only 283 of that group then went for that first appointment, and 250 actually made the final decision to start hepatitis C therapy. And only 88% of that large group actually started the therapy, and 7% had a cure. Okay, so this is an older slide before DAAs really became popular, but we're seeing similar continuums, right? We're not, for the huge number of folks that are living with hepatitis C, our ability to cure is very limited. And here's another one that talks about, it's just a different way of looking at that treatment cascade for hepatitis C. And again, you can see that very small number that actually get to the point of being cured. So the leaky pipe. So in both of those continuums, at certain times, folks fall out of the continuum. And when those social determinants of health are not met, they've had a relationship breakup. They've had an addictions issue. They were on methadone and they drop off methadone. Something's happened in their personal life. There's been a death of someone close to them. They've had some sort of trauma within their life. They fall out of that, they fall out at any point. It can be as they enter the continuum. It may be right before they start taking medication, or it may be in the case of hepatitis C, maybe they started medication and they drift away. We had a gentleman that thought he'd like to stop his methadone. He was kind of tired of taking methadone and thought he could stop methadone cold turkey. And so he was off his hepatitis C medication for his DAAs for 14 days. So we haven't got to the point where we're looking at SVR12 to see what happened because he missed 2 weeks. He was so mad at himself when he came back because he said, I thought I could do that methadone by myself, but I didn't even think about the hepatitis C medication. And so, what can we do? Started him up again, and he completed out, and we're just waiting for blood work. So it's really important to get those folks, and that's why I'm out there. I see lots of folks that are that water that's dripping out there. They've fallen off. Having that conversation, helping them understand that folks do care. Let's get you an appointment at the clinic. Let's get you back on your HIV medications. Finding out what are the problems and seeing if we can solve those problems and getting them re-linked or re-engaged to care. Sometimes folks don't even realize, wow, was it really last June when I was seen at the clinic? Gee, I didn't even realize that. And there were, folks had arranged appointments for them a couple of times and they were no-show. Sometimes they've forgotten totally about it, didn't realize that there was an appointment for them, or someone did try to come and pick them up for the appointment and they weren't at the address, they've moved on. So just because of the transiency sometimes moving from place to place, it's very difficult to keep in contact with some of our population. So when we first started talking about this project, we began to think about where would we go? Where should I go? What location should I? So those were the first steps. Need to see what has infrastructure, what can support the presence of a nurse, once or twice a week. Is the clinic ready? And that includes both the staff. Are they accepting? Are they okay if I come in and sit in their space and talk to their clients? And what about the clients? Are they ready to come and talk to me? So you need to have those conversations. And in my case, I was lucky because Danae had done lots of work, and she and the group had been out and done some outreach clinics. So some of those barriers had already been met. And it was just the fact that there was going to be someone there more frequently than, say, once a month. So you have to have a plan and goals, and you want to have the staff input. What days are going to work best, and what day is there phlebotomy on site? And we'll talk a little bit about that in a few minutes. What day can someone have blood drawn? So if I'm there, it really makes sense to have someone that can draw blood there as well. So engaging the staff and, having them welcome you and feeling a part, even though it's sort of on the fringe, a part of the staff while you're there that day. Asking for feedback, always talking to them about, what's happening. Are you hearing any complaints? Do you think that there's anything else that, that I should change? Is this the best day? Are the times working for you? Am I in your way? You want to make sure that you're in their space, so you don't want to be in their way. And it's constant assessment and adapting. So I've come a long way over the 6 months from the first day I kind of went out there. It was like a nightmare. I had to use a hotspot to use the computer, and someone had logged in on the computer overnight, and so I couldn't use the hotspot, and it was just like thinking, oh my gosh, is this really the way this is going to work? But and loading up all the different pieces of equipment that you need to every day can be a little hassle. I've certainly learned things that I need to take with me every day and things that I don't take with me every single time I go. So it's adapting and moving forward and making the best use of what I have with me on the day that I'm out there. So taking your time and thinking about things, I kind of jumped in, and started. I would certainly suggest consulting with somebody that had done a project somewhat like this to take your time, look at the situation, make sure, because if you start going to a community-based location, I'm not sure that it would be very easy for me now to say, whoops, I don't think I want to come to this location anymore. I want to go somewhere else. They become very dependent. They like having you there. You are a resource for them as well. For example, one of the community-based organizations I go to was very interested in naloxone kits. And when the rules changed around naloxone kits a few weeks ago, they brought in, and I think I've educated almost 20 of their staff over the last couple of weeks because, and they was just making the best use of me. And so I felt, it was just a way to connect with the staff, and they were very appreciative of that. So structure, developing protocols. So you have to know, you have to have connection. For me, being a nurse out in the community, I have to have a connection with a physician. So I have the support of Dr. Wong here in Regina for anything I do, and Danae as well as the research in hepatitis C nurse. I often pick up the phone and talk to them, and as well the research team if I have, it's a two-way communication. They might be looking for someone, or I found someone and I want to know if they need to talk to them or if they need me to get blood work drawn, etc. I need to know what the workplace resources are. Do I have a quiet, private place where I can talk to someone in a confidential manner? Most folks are very worried. Again, that we go back to that stigma and discrimination piece. They are very concerned about, can anybody hear our conversation? How, the door is shut. Can anybody is there anybody out there? Can anybody hear? Did anybody see me come back here? As I've been talking more and more to folks about a variety of things, they understand that because I take vaccine with me, it may be just that they're simply coming back for immunizations, because everyone's welcome to come and to talk to me and for me to look them up in Panorama, and maybe they need simply, an updated tetanus, a Tdap, or something like that. So people have begun to know that people just come back and talk to me. Another focus that I have and I always worry about, or if I see a woman that's pregnant, I always try to engage them in a conversation. Are you engaged in prenatal care? If not, and many of them are not, how can I help you? Where can we get you an appointment? What can we do? Are you tested? Have you had a recent test for HIV and hepatitis C? No, let's get that blood work done. So I now have the prenatal panel that I can get drawn and get them appointment over to somewhere within the community, somewhere they're going to be comfortable with. What kind of supplies do I need? So sometimes I can engage a population simply by having a Band-Aid. Had a little boy last week that fell on a piece of rebar and came screaming into the methadone clinic. And I was his best friend because I had a Band-Aid in my bag. And it wasn't even a fun one either. Just a Band-Aid and a granola bar, and he was happy. So it's just, thinking of those extra little pieces that you should have with you. And what are community resources? So it's not only community resources, it's everyone that I might need to interact with. So I always make sure I have a full telephone list of everybody that's out there. You know, I can talk to, who can I call at the clinic? Who can I call at public health? Who can I call for their family physician, for directions, which is a community-based healthcare in Regina, in the urban area close to where I work out of. Who else can I help? Home care. How can I reach to home care? The pharmacies. So it's all about making sure that I know those community resources, and I continue to add to my list of community resources. Mental health. I have someone on the go with mental health, trying to make sure that we're all on the same page when we're talking about hepatitis C treatment for a client that is someone that's heavily involved with the mental health clinic. So again, we talk about engagement. I needed to make sure that everybody kind of understood, and I think that was something that I didn't do a great job about. The folks that I work with directly at public health knew most of what I was up to, but the clinic didn't always know right at the beginning what I was up to and what I could do out there. And sometimes they challenge me and take me to the next level too. Are you sure you can't do that for me? So we'll see what else we can do out in the community to keep folks healthy and happy and on their meds out in the community. So meeting clients' needs, which is really why I'm there. What does the client need? But I think you have to look at what does the client want? What does the client see as their needs? What I think and what they think might be two different polar opposites. What resources do they already have in place? So it's always good to ask those questions, to have a look. I wouldn't say I've been burnt, but I've had my eyes opened a couple of times when I realize what all is happening for someone already in the community. What are the available resources? And then that word advocacy comes in there, because sometimes I have to advocate. And it may be that someone thinks, no, that isn't my job, but maybe I feel it is. And let's just, have a conversation about how we can work together to have this happen. Do we have a timeline? How long, do we need to do this right now? Do we need to get someone so last week I had someone that came into the clinic or 2 weeks ago, I think, and he had thrush, a mouthful of thrush. And I said, do you have an appointment? Well, I think I have an appointment today. So sure enough, he did. And lucky we hadn't missed it. So I took the community-based organization, has a driver there. Lucky she was sitting there, and we all worked together and got him to his appointment on time. And he came to me next week and stuck his tongue out at me because his thrush was much better. So anyway, those are the small things that make you feel good at the end of the day. And another thing is to avoid conflict. So sometimes it's trying to talk to a client who's had a bad experience somewhere. Not often, very rarely do they ever talk about their bad experiences with public health or with the clinic. It's bad experiences when they were admitted to hospital, bad experiences when they were seen in the emergency department. And so it's talking to them about, for example, someone that signed themselves out and they come to the methadone clinic and they really shouldn't have signed themselves out. How do we get them back to hospital? How do we talk them into going back into a situation that they weren't happy with? So as a healthcare provider, every good conversation starts with listening. So sometimes I think of many of the clients I talk to as a layer, as an onion, because to get down to be able to talk to them about hepatitis C, I have to talk to them about a traumatic event that maybe happened. Someone was telling me recently about someone that they had found that had committed suicide. So we had to have that conversation and make sure that all those pieces were in place before we could advance on to what I really wanted to talk about, which was the hepatitis C piece. Or the fact that, someone has just recently died within their family. So you have to have those conversations first before you can get really to the meat of what you want to talk about. You need to be flexible. So sometimes getting blood drawn today isn't just in the cards for them. They don't like the phlebotomist that's there today. They had a bad night. They missed their methadone over the weekend. Whatever reason, it's not today. So by forcing them to do something, I'm just not going to win them over or build a relationship. So, okay, I'm back here again next Monday. The person that's drawing blood is back here Monday. Let's do that together next Monday. Have to be forgiving, because often they'll come back to you and they'll say, I'm sorry, I forgot to do this, or no, that's okay. What happened, what got in the way. We work through it, and, be very understanding. Problem solving as well. Many of the problems aren't something that's related to what my agenda is. But if I don't help them solve the first problem of the day, I'm not going to get to the second problem, which is what on my agenda. So it's being able to be, again, all of those above, flexible and adaptable to help them problem solve to get to where you want to be. You have to be very accepting. And I think that goes without saying. We should, a nurse, that's just heart of our culture. We need to be accepting and we need to be a good listener. So what are some of the successes? So definitely I have linked, and not always, I've linked them back to care. I've gotten blood work done, but still have pieces to put together, because of course linking them back to care means getting the blood work done, getting them up to date, getting them linked back into the clinic. And so, even all my hard work, making sure public health, I have updated their address and their contact information. Public health is aware of all that information, but still they've missed the appointment, because when public health goes to pick them up that day, maybe they're not there. Something else has gotten in the way of them being able to attend that appointment. So we start again back at zero and we try again. And it's a never give up. I never give up. So testing to those with no recent testing. So I'm always lucky I have eHealth, and I talk to the client. I said, let's have a look in eHealth. When was the last time you had an HIV and a hepatitis C test? And without fail, almost every single day I go out in the community, I find someone who says, I don't remember the last time I was tested. So yes, back in 2013 or 2014, they had a negative HIV test, but there it was. They have a hepatitis C test that's reactive, an antigen that's reactive, and someone even had a viral load there. And they go, really? I didn't know that they did that. I didn't know that. So you have those conversations, and it's, for some folks, again, you can't push your agenda right that day. They have to absorb that information. Attendance at appointments. So, we're working on it. We get some folks there, just like the gentleman that I got with the thrush. He got to the appointment, got the medication he needs. Whether he gets to the next appointment, well, maybe, maybe not. I see Darla laughing at me. But, he knows it's someone that I've known for a long time. So when he sees me coming, he gets somebody who walks towards me. Updating immunization. So I always have vaccine with me. Limited vaccine, but I have Hep A, Hep B, Tdap. I have Pneumovax and Twinrix with me. So updating immunizations, especially I do, one of my sites is out at the correctional facility. So that's an easy place to, and they're only too welcome. Very rarely do they say they don't want to be immunized. They're only too accepting of whatever you offer them. And slowly, as I mentioned before, clients are beginning to ask. Sometimes it's just because they know that I have a granola bar or some kind of a treat, or I'm willing to give up my fruit that I have for lunch out of my bag. They'll come back and ask. And so that's all the way you need to engage them. Little baby steps, small steps. And when they have a bigger problem, hopefully they'll come and talk to you. Some of the challenges are phlebotomy. So having phlebotomy at my right hand would be great. I know, I certainly could draw blood myself, but these folks are very challenging. And for a couple of the sites that I go to, they're probably the hardest of the hard to draw blood on. And so having that expert there that can do it with one poke rather than me trying to fish around 4 or 5 times, I think that would be a relationship breaker. They're not going to want to come near me again if I've had to poke several times to get their blood. Definitely some are easy, and that wouldn't be a problem. The other piece is when you're drawing blood, you want to draw everything at the same time. So you're drawing an HIV or hepatitis C viral load, which changes the dynamic around the blood draw, because they can't sit out in the community. They have to be picked up and whatnot. So it's a bit of infrastructure problem. Clients who aren't ready to engage. So I have, I forward them. I either put a task into the electronic medical record. So that's a great friend of mine, because I can look in that electronic medical record and see when their last appointment was. I can see what their latest blood work was. I can read the latest note that says, well, they didn't like the medication. They're just on a new HIV medication. And I can talk to them about that. I can send a task back to Mike, the clinic pharmacist, and say, hey, Mike, I'm talking to so-and-so. They've got this side effect. Give me some advice, or did you want, what should we do about it? And so there's lots of different ways to communicate, and I can see the whole picture of what everybody that's on the team may have been doing for a client. If they're part of the research team, I can say, I can see the research team is trying to find you. Do you have a new telephone number? Or let's simply get them on the phone here, and you can have a conversation about where you're sitting with me. So definitely some days are better than others. On average, I see about 12 folks a day. Sometimes I see more, sometimes I see few. Our community goes up and down. The community organizations go up and down. When I go to the community-based organization, because I'm on site, we serve lunch. And so that usually brings in somewhere upwards of 30 to 60, depending upon the day and what's happening within the community. So there's definitely lots of folks to try and engage and and talk with, and new faces all the time. The same with the methadone clinic. Some days folks love to come over and talk to the actual supportive side. Some days they hop out of the cab, grab their methadone, and hop back in the cab, and so you don't have the opportunity to engage them. But by using the medical record, adjust the electronic medical record, just pop their name in a couple of days, a couple of weeks in advance, and then look for them again. Oops. So that was my final slide. Does anybody have any questions for me? I just, I certainly will be glad I'll be at the event in now. What is the date? The HIV Hepatitis C group will be having an event in Prince Albert in September 28th and 29th in Prince Albert, and that is a free event. So that will be, and I'll maybe get Kim to send that out on the Google group as well, again, now that I've talked about that. I just wanted to let you know that the next session, before I open it up to questions, the next session for HIV rounds will be done by Mike Stuber, who is the clinical pharmacist here at the Regina General Hospital, as well as he's the provincial HIV pharmacist. And he's going to talk about changes to antiretroviral or HIV medication coverage and the process for a physician or a care provider, nurse practitioner to become an HIV prescriber. I just want to remind you there's lots of valuable information on the provincial website at skhiv.ca and the Google group as well. So if you aren't a member of the Google group, I think most of you are, but if not, certainly spread the word to anyone else within your circle, within your workplace. And you can talk to kim.lane@saskhealthauthority.ca to become part of the Google group. Kimberly. Oh, sorry, Kimberly. Lane. Lane. Okay. But I'll open it up. Does anybody have any questions? Anybody questions on site here? No? Anyway, thanks very much for spending your lunch hour with me, and I look forward to maybe interacting with some of you if I find someone that's lost a follow-up from one of your locations. Thank you.